Thanks very much, Kat,
Hello,
and
hello.
welcome in everybody. We're having a couple of Zoom issues this evening that we've been trying to fix. So here we are. At least we're online and getting working. Isn't that right, Kat?
Absolutely. We're here. We're waiting for everyone to come in. And I know there's a couple of questions. There's been a couple of questions on Facebook of people saying, has it been cancelled? But I think we just had a bit of a glitch, didn't we? So
Yeah.
hopefully, well, obviously all the people that there are a lot of people coming in now. So all the people that are coming in now have got in.
Yeah.
And hopefully, if you do see anyone, if you've got any friends saying you're struggling to get in, they will have had a link last week and they'll have had a link an hour ago that they can get in on. So please do remind your friends if you've got anyone who's struggling to get in, remind them that they've got it. Hi, Rory. I've just noticed that you've managed to get in. So I'm
Oh,
really
good.
pleased about that.
Hi, Rory.
Hi,
We'll
Rory.
repost. We'll repost the recording for everybody as well, anyway.
Is the chat working for everyone? I want to see. I'm just wondering if the chat's been switched on for everyone, because then people can ask their questions either through that or I don't think we've got an ask a question box up, have we?
Um, so let's say hi, everyone.
I've got that one. I wonder if because no one's able to write back. I don't think. Is anyone able to write? If you, I suppose you wouldn't be able to tell us. Hang on. Let's see. Oh, there is 3 Q&A. Chat is disabled, it says, Siobhan.
I have got it on everyone.
It's all right. People are still coming in anyway. We can spend some time looking at it.
Yeah, it does say everyone there.
I think it's in settings, is it?
I'll play around with that afterwards.
Amazing. Amazing. But anyway, the Q&A is working. So if anyone has any questions, why not just pop them in there and I'll keep an eye on them. And that's not a problem.
We'll
Oh,
just try the. Yeah, here we go. Here we go.
hello. Hi, everyone.
Okay.
Well, it's Thursday. How has your day been, Siobhan? Has it been busy?
Hey, actually, the sun has been shining. My little boy was off, so we went off into town and things like that. So it was lovely. And
That is
your day, you're really busy in surgery.
busy in surgery, full list, all sorts today, checkups, emergencies, hygiene, consults. I'm working closely with an implant dentist at the moment, so we're back and forth into each other's rooms. So it was a little bit mad, but we all love it that way, don't we? We don't want to be
We love
stuck
it
in
that
our
way.
room on our own. So I'm super pleased. I'm super pleased. It was a good day, full of energy.
Perfect. Well, let's get started. And we're going to say welcome everybody to the Essentials of Composite Maintenance with the lovely Kat Edney. So I'm going to hand over straight away to Kat. You're going to tell everybody who you are again in case we have any newcomers, Kat. And just Kat's a dental therapist and does everything about heightening awareness of the role of the dental therapist, puts her head above the parapet, involved in lots of organizations. So absolutely, thanks, Kat, for all that you do. And we're going to hand it over to you and let you go from here. Thank you.
So much. Thank you. Well, welcome to Thursday night cozy sofa chat I was talking about before. And thank you for the introduction, Siobhan. Yeah, I am all about championing our profession, both hygienists and therapists, obviously. And I'm so pleased that we could bring you the essentials of composite maintenance this evening, because I think it's something that we don't really talk about a lot. I think something that a lot of the profession don't really realize is that all of the work that regardless of whether the dentist is doing it, a specialist is doing it, a therapist is doing it, all of the restorative work that is happening out there has to be looked after. And we all know, because we see these patients coming through our doors, and you often think, oh my goodness, who placed that, or look at what I've got to manage or deal with. And sometimes you might feel the opposite. You might think, oh my wow, this, I've seen some amazing work. I couldn't even tell that it was composite work, or I couldn't even tell there was a filling there. And that's all down to how that restoration has been managed and how it's been looked after. And I'm really hopeful that today we can look at how, as a profession, we can also look after those restorations and just make sure we're doing the absolute best we can for our patients. So your obligatory aims and objectives we'll go through. So the aim today is to take an in-depth look at how dental hygienists and dental therapists can employ modern techniques to maintain composite restorations, with a look at some key equipment choices and treatment protocols to support gold standard patient care. And that's what we're all about, isn't it? And I know that every single one of you that has logged on to see us this evening really cares about delivering gold standard care. So me too. You know, I wouldn't sleep if I didn't feel like I'd done the best I possibly could every day. So I think it's something we all share, is this passion. And then our objective, so how are we going to reach that aim, is I'm going to today describe the growing need for awareness around composite maintenance, explain the indications for different types of composite maintenance techniques and equipment, demonstrate to you the techniques required when maintaining composites with some specific equipment, especially some of the bits that I choose to use. Obviously, you know, I may not be able to go through everything that's out there, but some of the bits that I choose to use. And then just outline our communication goals when treating patients with these composite maintenance techniques. Ultimately, we need to make sure that we're also protecting ourselves. So we'll look at all of this today, and we can go through it all together. So why do we need to know about maintaining composites? Well, you tell me. All you need to do is tap in composite bonding to any social media. I mean, I'm like a little bit stuck into Instagram. I think I'm too old for TikTok and stuff like that. But type in composite bonding. What are you going to come and find? It is everywhere. Am I right? It's just blown up. And it's just a super popular treatment at the moment. People see it as transformative, quick, relatively cheap, and they see it as something that they can just go ahead, get done, and their teeth will be fixed. And there's a lot of evidence to show that that it's becoming even greater in popularity. Now, this is the Google Analytics for the term composite bonding. So if you ask Google, how popular was that search term, you can see this massive peak in 2020. And I think a lot of us know why that was. Obviously, 2020 was the year of Zoom. It was the year that we all got online. And it's certainly the year that I was like, oh, look, Kat, you might need to whiten your teeth. So I think we all had that kind of feeling of like, oh my goodness, I can see my face now. And I know that an awful lot of office workers, people that don't often get onto camera, now we're having to face reality. And so there was a huge spike in cosmetic treatments required, Invisalign or tooth straightening or tooth whitening, but also composite bonding. You can see that spike on our Google Analytics. And then there's your obvious influencers. Oh, love Molly May. I feel like her teeth are not like that anymore. I think she went back to her dentist at Rue Dental and had them changed. And also Ryland there, we know he's also had that's composite bonding, but he had veneers now. So, you know, look at me knowing all these like little celeb influencers. So yeah, we have these influencers that are influencing the general public. We've got Zoom that influences the general public, and we've got this new treatment modality, which obviously we all know has been around for years and years, but it's become ever popular. And listen, I'm not immune. I'm doing it myself as well. I personally feel really odd about covering up beautiful, natural, healthy, stunning enamel. But there are some indications, obviously, where we will use some composite bonding as well. So this is Lucy. She is just the loveliest patient, just the nicest person. And she was a patient of mine for quite some time. And eventually she came to me and said, Kat, I'm ready. I'm going to straighten my teeth because I'm going to get married. And I was like, oh, this is amazing news, because we've been talking about straightening them for a while. So that's incredible news. When's the wedding? She was like, do you know what? Shotgun wedding, 3 months. you're not going to have time to straighten them. So this was one of those occasions where I have used composite bonding to kind of mask the fact that her teeth were not perfectly straight. So a little bit on the upper right lateral there, a little bit on the upper left central there, just to make it, you know, look slightly straighter than it was. So there's no orthodontics involved, and this was you know, a temporary result that we achieved. But in order to keep it staying like this, Lucy has to put in the work and the effort, and so do I. Okay. Otherwise, if you don't look after your composite bonding, and this is another one that another patient I've seen, I've taken some pictures of. If you don't look after it, it can stain, it can chip, it can get rough, it can pick up stains, it can pick up biofilm, and it can become a bit of a problem. And rather than really helping the patient aesthetically, it starts really hindering the patient's aesthetics. So this is where composite bonding, composite maintenance is really, you know, coming in. And then how many of us have had patients that have not maintained the work that they've got in their mouth? I think we're all able to relate to having some patients that come in looking like this, and you think, oh my goodness, how have we got to this point? And how is it still like this? And how are you in my chair? Why am I dealing with this? So yeah, I think, you know, really important to know what are our limitations, what can we do for patients like this, what can we not do for patients like this, and what do we need to say to patients like this if we decide we are going to treat or try to improve the situation they present with. Now, a lot of this will depend on how confident you are as well. So I'm going to talk through a few different things today, but there might be times that a patient comes into the chair and you think, actually, I don't feel like I want to deal with this, and that's absolutely fine. But there are obviously, throughout our profession, there's people who are super confident, people who are, you know, growing in confidence, and there's people who just really don't want to tackle it. So those of you that have logged on today, I think you're those growing in confidence kind of people. So we're going to look at how we manage those kind of situations. The first way we need to look at it is to understand why is it that some patients come to us with really beautiful bonding that's you wouldn't even know, and why there are some patients where we really, you know, can't understand how it's stained so badly, or it's chipping, or it's dull, or what's going on. So the first part of understanding that is really understanding the type of composite that is being used. And obviously, if you haven't placed the composite, you will never be able to guess exactly the type of composite, or, you know, unless it's written in the notes by your dentist that did it, you'll never know what type of composite. But it is good to understand that there are many different types, and that they can behave in different ways, and they have different functions. So all composites contain a number of components that make up the mass of, or the bulk of the composite. So the first thing is it's in this matrix, and you've got to think of that matrix as like a swimming pool. Okay, so it's this swimming pool of like flowing plastic, matrixy plastic. And within that swimming pool is loads and loads of filler particles. So that's like your big floats, okay, in the swimming pool. And then you'll have coupling agents. Coupling agents are like the kids that are holding on to the floats and trying to get them all for themselves. And initiators and accelerators are people going, the parents at the side going, don't let that other kid get your float. And they're all like grabbing on and holding. Initiators and accelerators are what makes it set. Okay. So you've got your filler particles floating around, your coupling agents that hold them together, and your initiators and accelerators that make them set rigid. And then apart from all of that, it's your colors, your pigments, what makes it tooth colored, or in some people's composites, it's kind of not tooth colored, it's more kind of just white. So we also have our pigments to make that work. And then really, depending on that filler size, that gives us a better understanding of how big it is, and how big the filler is, and how much filler there is. That gives us a better understanding of how that composite resin will work. So if you've got smaller filler particles in your swimming pool, so lots and lots and lots of small floats, it's easier to polish the surface of that composite. But when it's got small filler particles, it can be a little bit weaker as well. Okay, so it's not amazing when you've got these small, low amount of filler content in your composite. Those composites are not great for posterior teeth that get lots of occlusal loading. They can fracture, they can break, they can crack. It can be a bit of a nightmare. So then, you know, we think, okay, well then let's use really big filler particles for really strong, durable composite that's not going to go anywhere. And the problem with that is that it leaves lots of gaps around those large filler particles, which result in a rougher surface. It's harder to polish, and it's much more likely for the swimming pool, for the matrix, to suck up stains. So you might have really hard, really great strength, but they go brown, okay, and they don't hold a shine. And having that understanding, and especially dentists and therapists who are placing composites need to have that understanding, because they shouldn't necessarily choose the same type of composite for posteriors, non-aesthetic area, as they should for anterior teeth. So what should the structure be? Well, in the grand scheme of things, composites have come a long way over the years. When we first started, we can see we started with macrofill, which are those giant filler particles, and not very many of them, lots and lots of large angular edges, which is what made it really rough and difficult to polish. Then we moved into the era, the 80s and 90s, where it was an era of hybrids. So they thought, okay, we know we need the large particles for strength, but we want to then put loads of little filler particles around that so that we can start polishing. And that was a lot better. So it's really only in the 80s and 90s when composites became aesthetic enough to really create good results or acceptable results for anterior teeth. And then now we've moved into the nanohybrid phase. And nanohybrid phase means that we've got a massive mix of large macrofill particles, the smaller hybrid style particles, and then really tiny particles. And then having those nanoparticles, those really tiny ones, means that you can get beautiful shine on your composites. And because they're really durable as well, they don't tend to shrink because there's not so much unfilled matrix or swimming pool. It means that they are really great for polishing, really great for handling, and they can be pretty good for your strength as well, so for chipping issues. So for anterior teeth, we tend to try nowadays to choose a nanohybrid composite. So if you see a restoration on a patient and you say, gosh, when did you chip your tooth? Oh, I did that when I was 12 years old, cycling my bike. Come on, how many of us have heard this story? I was riding my bike and I stopped and I went over the handlebars. Or I was hit in the face with a baseball bat. Or I dived into the swimming pool, dived into the swimming pool and I hit my front teeth on the bottom of the pool, right? All of these stories are really common, aren't they? And yeah, you're right. Don't allow my children to cycle, play basketball, play baseball, or dive into swimming pools. So, you know, you'll hear these stories and they'll say, but that filling's been on there forever. You know, it's been on there 20 years, it's been on there 30 years, and it's doing really well. And I don't want to change it because, you know, it's not come off, right? But you might notice that it's not glossy, it's not shiny, it's a bit off on the color because it's sucked up some stains. So you can have that conversation and say, you know, like the filling material that we use nowadays has really come on. And not only is it stronger, but actually it polishes better and it doesn't pick up the stains so much. So it might be a nice conversation starter for some of your patients. Here's one of those incorrect composite choice patients that came in to see me. And it's really frustrating because you can tell that the bonding has been done quite rudimentarily. and they haven't really finished it very well. So there's a lot of pitting on the composite, and it looks like it was not polished very well. Now, I have chosen not to refinish this composite, and the reason being that it was placed, the incorrect composite was used to place anterior veneers, and the patient knew it, and the patient was really unhappy with the result of their bonding. They knew that it was picking up loads of staining, and they knew it was going to need to be redone. So I was just doing an initial clean and consultation, and then sending to our cosmetic dentist, who will be removing all of that composite and actually probably placing porcelain veneers now, because this in patients high risk for stain anyway. So composite probably was never the right choice, regardless of the type of composite. So if you have the wrong composite placed on your patient's tooth, or if the person placing the composite doesn't follow the right polishing protocol after they've polished that, after they've finished placing that composite, then you're going to be high risk for stain. And you can see they just generally dull, right? Not very nice, not an amazing result for that patient, which is very sad. So what can we do? What can we do as hygienists and as therapists, really to maintain these, beautiful anterior restorations that some of our dentists do, or some of our therapists do, or we're doing ourselves? What can we do? Well, the first thing is the patient has to take responsibility for the work that's in their mouths. And I can't stress that enough. Before any work is done on any of my patients, the conversation is had that the only reason they're having the work with me and my patients, because I don't tend to do cosmetic work for no reason. The only reason that we are putting this stuff in your mouth is because you did not look after what you had, right? You either broke it, you've been chipping it, you've been grinding at your teeth, you have caries, whatever it is, you've worn it away, whatever it is that caused them to need me to treat them, they need to ensure doesn't happen again to this work, right? Because nothing is going to be as good or as strong as your natural tooth. So the first thing is the patients take responsibility. Quite a few patients could benefit from having nighttime splint. Obviously, I know we can't prescribe that, but it's well worth having that conversation with your dentist. This patient's got loads of bonding. They've got really big masseter muscles, high risk of chipping and grinding. What do you think? Maybe we should have a splint for this patient. And then on top of that, it's the maintenance of exceptional home care. So oral hygiene absolutely has to be the best. And again, this is a conversation that I'll have with my patients, that if you're going to have any anterior work done, you cannot come and have it on the day. You cannot have it if you've got bleeding. You cannot have it if your gums are inflamed. Ultimately, it's going to compromise the result. But also, it's telling me that you're unable to look after your teeth. So you absolutely will be unable to look after the bonding and the composite. So patients need to know that they have to provide excellent oral hygiene care at home. And in addition to that, sometimes it's not possible to get the most beautiful, cleanest margins in the world. It's not possible to get bonding done that has no ledge or has no edge or is not detectable. And patients need to be aware that it may be harder to maintain their bonding than it is to maintain their natural teeth as well. And then other than that, I do recommend that bonding on teeth, composite on teeth, regardless of whether it's anterior, posterior, buccal areas, facial areas, it will need a repolish. Because again, it's not as durable and hard and glossy and amazing as enamel is. Okay, it's not the same. So it will need a polish every 6 to 12 months. And I've said if necessary, and I so far don't have very many patients who don't need a little polish up. However, Lucy, who you saw at the start, I show her in loads of my presentations. So I'm super, super proud of her. Her teeth have always just looked pristine after that. So she's a funny one. So anyone that's having composite bonding gets this composite bonding maintenance advice. You are welcome to have a little screenshot and take hold of this if you want, but you can also just email me anytime. Pop me a message, DM me anytime you like, and I will just send you this as a document. Not a problem. So this is instructions for maintaining your dental composite bonding. And this is what we talk to the patients about. So they must have this amazing oral hygiene, and that includes flossing. If they've got space for TPs, then we get them to use TPs in addition to flossing. So for me, they need to floss for the contact point to be clean, as well as using their TPs. We talk to them about their diet and their lifestyle. So just limiting their consumptions of tea, coffee, red wine. And I talk to patients a lot about things that they may not consider as part of their diet. Sometimes they have turmeric tea, or they might have some sort of supplements that are iron based and could be quite dark. We talk about stopping smoking, trying not to bite on hard foods, using their teeth, so ice, nuts, hard sweets and things like that, cutting up their apples, cutting up crunchy vegetables to bite-sized pieces, trying to not use their teeth as tools, because that's the biggest bugbear when a patient says, oh no, I always look after my teeth, and then they're biting their nails in front of you. And then it goes on. So please feel free, like I say, to pop me an email if you'd like a copy of my maintenance advice. Part of that maintenance advice is thinking about how abrasive is the toothpaste that your patient is using. And you may be surprised, because I don't know about yourself, I always ask, what toothpaste are you using, as in not just fluoride, but actually the brand. I want to know the brand. I want to know the type of toothpaste, because quite a lot of patients don't realize quite how abrasive their toothpastes can be. So for instance, charcoal toothpaste can be on the relative dentine abrasivity chart, they can be as high as 166, which is super high. But then look, Arm & Hammer are also higher than that. So it's something that we do need to be wary of, that there are some toothpaste that could potentially be in the harmful limit when it comes to relative dentine abrasivity. And composite tends to be a similar hardness, maybe slightly harder, but a similar hardness and modulus of elasticity to dentine. So if you think of your dentine as being, kind of like spongy foam, and your enamel as being glass on top of that, your composite is some way in between those two hardness. So it is really important that patients understand that your composite is likely to wear away faster than your enamel as well. So enough of me talking about that. What are we going to do about it? What are we going to do about the stains on our patient's teeth? We're not placing the composite, Cat. So stop going on about it. Okay. So what are we going to do about the stains on the teeth? Well, we can have our traditional composite polishing processes. So, polishing points and things like that. And these are really, really valid options, which we will talk about a bit more. But for day-to-day general hygiene maintenance, I personally, use piezo, ultrasonic scaler, and then powder therapy, so air polishing. And I will always use a combination of the two. So the first thing is piezoelectric. Obviously, we know that when it comes to using a piezo handpiece, the waves that make that, there's the ultrasonic waves that make that handpiece move, make it move in a lateral direction. So just the lateral sides of that mean that if you can sit the lateral side of your ultrasonic scaler onto the surface of your composite, it shouldn't rattle around or make a squeaking noise. So if you're adapting that to the tooth absolutely perfectly, it won't rattle around, it won't make a squeaking noise, and it's actually the least abrasive or least likely to cause problems on your composite when you adapt it correctly. So that's the first thing. If you've got composites that have a little staining, especially a little bit of staining on the surface of the composite, you can very well just use a piezo and get rid of it. What you might notice, if you get the angle slightly wrong, sometimes on composites you get those little grey lines. And that's where you're losing a little bit of the piezo tip onto your composite. Obviously, we don't want to be sort of leaving that there, and it does polish off, but just be a little bit wary. You may be slightly off on your angles if that is happening. So just readapt your angles for your piezo. When I'm using my piezo, I do like to use the P20 tip. On my NSK handpiece, and this is the P20. You can see it is really long and fine, so it's great for getting around, larger teeth or into sulcuses. It's really small and thin and fine, so if you do have any mild overhangs around composite veneers, this really long fine tip can be really helpful for just getting, that annoying yellow plaque, sticky plaque that you might see patients pick up. This tip's really fantastic for that. And because you will have it on the P setting on your chair or on your Varios, the P setting is for much lower frequency ultrasonic waves. So it means that it's really gentle, really mild. And you can just remove biofilm and stain on the composites with that. So I really like this one for easy general, and also for getting around difficult margins, even on veneers. Actually, I'll use this really gently just to get around those difficult margins, especially if you see that sticky yellow. Love it when you get that. And then obviously powder therapy with air polishing. So, you may have heard me speak about it before, but air polishing is just much more effective and comfortable, generally in a shorter period of time. So I like to combine both treatments if I can with patients. And obviously that jet of air, powder and water, they're really effective for removing stain and biofilm. And there are tons of different products on the market. So I use, as you know, the Varios from NSK, but there are so many different products and hand pieces and different powders and all sorts on the market. You're welcome to log into my air polishing webinar, which will be coming up next month, and we can talk about all of those different powders. But I will just go into detail of a couple more for you today, just because I want to show you the ones that I'm using. Okay. Love a slow-mo video, don't you? So the reason that the powder doesn't clog is because, or it shouldn't clog, is because the powder and the water actually meet outside of the tip of your air polisher. So it's really important to remember that, because the point at which it meets is the point at which it's most effective. Okay, so that's one thing to remember. So if you're finding that it's not really removing the stain, or you're trying to pinpoint certain areas, you need to move your handpiece in and out in order to get to those areas. And then when it comes to using powder therapy on your composites, we need to really understand really in depth, what am I actually using and what am I choosing to use? Because obviously different powders will have different hardness. It's going to do a different level of damage on your composites. Okay, so it's a case of being really aware. Now, Catherine Mayo and Jenny Walker very kindly put together this lovely flow chart, which is a really nice, simple way of showing us what we can use what powder for. So, you can see composite there is very clearly in the subgingival powder or low abrasivity category. So what we're talking about there is your glycines and your erythritols and your trellohos, those sort of really small particle powders, which are low abrasivity. That's what you can use for your composites. Okay. Now, the evidence or the research says that it doesn't matter who places it or when it's placed, all composites, all restorations do need to be maintained and polished to reduce your plaque stagnation, to reduce plaque retentive factors. The extent of composite surface damage, it very much depends on the material that the composite, the type of composite that's been placed. They are also saying that sodium bicarbonate, so your inorganic powder, sodium bicarbonate will have a stronger detrimental effect on composite surfaces than glycine or erythritol, which are your organic powders. And those are the ones that are generally low particle abrasivity, small format particles. And this study also says no advantage between erythritol or glycine, so you can use either. And then the lowest roughening of composite surfaces tested was obtained by air polishing with glycine for 5 seconds. And that's a 2014 study there. So just wrapping all of that research up into one easy infographic. Actually, you've got your extent of composite surface damage really high when it comes to using inorganic powders like sodium bicarbonate, calcium carbonate powder therapy. And then, moderate damage if at all, with ultrasonic scaling, and then really no damage really using glycine and erythritol, tagatose for your powder therapy there. So you may find that you can maintain composites with just organic powders, and that the patient's got great polished, really well polished composites, just a little bit of biofilm on them maybe, and you can just run over there with low format, so small powder particle glycine or erythritol that's designed for subgingival use. So if it's designed for subgingival use, you can use it on your composites without too much worry, okay? And you're going to see the shine will still be there, the patina will still be there. It's the same as when you want to use that glycine on your patient's veneers or crowns or restorations. It's not a problem. It's unlikely to cause any damage. The glycine that I use is obviously NSK's Periomate powder. And I really love this one because it's really small. It's 23 microns, so it's a really small particle size. It dissolves, it tastes sweet for the patient. It's a Mons hardness scale of 2, which is the same basically or similar to dentine, and you can use it both on supragingival and subgingival tissues. And this is it working. So you can see that this patient has actually got quite a bit of staining. And if I use this in quite pinpointed circular motion for this patient, you can see that it is really effective for removing those stains. So actually I reach for my glycine powder a lot more often than I reach for anything larger format. So my subgingival glycine powder like this is fantastic really for general stains, nothing too hard, no like tobacco chewing or smoking patients, so this is a really nice one for that. And then what we want to do if we're using that powder is, as I say, trying to make sure that you get that nozzle the right distance from the tooth surface. So too far away and you won't have any power, too close and actually the powder and water won't have met yet, and so you won't be getting any efficacy through that. So you can use that nozzle at any angle, just make sure it's in the right place. And then what are we going to do about heavy staining? What are we going to do about when patients come in and they are smokers? Actually, this patient, bless his heart, he came to me during COVID the first time, and I'll never forget because we weren't doing any AGP type procedures, we weren't doing any aerosol procedures, but I hand scaled a lot of stain off, and also he had like a big old lump of composite caught between his centrals, where something had chipped off and he'd got it caught. So I'll never forget this sweet patient, but he always comes in with a lot of stain, always. It just is what it is. And it's always around that one composite restoration on that one anterior. So he has a margin there and it picks up stains. What can we do about it? Well, he doesn't want to replace the filling. Using my glycine powder, like my subgingival glycine powder, isn't effective enough to remove it. So what can we do about it? Well, this is the small format glycine powder on some heavy stain. You can see it works, but can you imagine if you've got a half-hour appointment and a patient with teeth this stained? It works, but it's difficult. It's harder to do. So yes, it will get the stains off, but you might be spending quite a long time trying to achieve that stain removal. If you've got a patient with composite bonding with loads of stains on it, you might have to accept that we use a larger format powder. It might just alter the surface of the composite ever so slightly, and then you might have to repolish the composite, or the patient might have to have the composite repolished afterwards, okay? So this is what we used to do. Before, we would use like a low RDA prophy paste with a polishing cup and really go at it. But the problem is, again, it will reduce surface gloss, and it can take a long time, and it can create heat, and it can change the patina essentially of your composites. So now I am using this. It's a slightly newer option. It's a large format glycine powder. So it goes in your supragingival handpiece. It's still really low on the Mons hardness scale, so it's still similar to dentine, but the micron size of the powder has been increased purposefully to be able to handle those slightly tougher stains while using a powder that is organic, that is dissolving, and that, you know, is appropriate for patients. So again, because it's large particle size, use with caution. It's not quite as rough as sodium bicarbonate or calcium carbonate. So it's not quite as rough, but it's still a large particle powder. So you will affect the surface of your composite using this. So use with caution, but this is when your patients have a ton of staining. And you can see the evidence is showing that there will be an effect on that surface texture in composite, but it's a small effect, okay? It's not a massive change. It's a small effect on the surface composite texture. So here's it being used on the same stain, same teeth, same patient. Lovely Mr. Plastic. And you can see when you're using this powder, it's far more effective. I always laugh at myself when I take these videos, because, you know, I'm doing it one-handed, trying to film at the same time. Everyone's gone on their lunch break, and so I can tell that, you know, I perhaps didn't do the best job, because you can't actually see past the tip of the handpiece. But hopefully you get the idea that it's far more effective. It works really quickly, and yeah, it's going to be much more likely that you'll get your job done with this. But again, you may need to then polish. So when you've got heavy stains, if you've got a ledge or a rough area on composite that keeps on picking up stain, and it's a plaque retentive factor that is, you know, stopping your patient from being able to do a really good job with their biofilm management, then if necessary, you can start looking at using some polishing discs or burrs just to restore that surface gloss and reduce your biofilm and stain retention. So I really love using these. These are Colza polishing wheels. They are, it's a two-step composite polishing wheel, and they're really lovely. They're super soft. And you use them on a really low RPM. So you use them around 10 to 12,000 RPM, so really low. And you use them with medium pressure, just the darker one first, and then the lighter one with a little bit of moisture. And I know you're all going, hold up a minute, Kat. Are you telling us to adjust a composite? Yes, I am. And I know I said at the beginning, it depends on your confidence, it depends where you are, it depends on how you feel. But yes, even in a hygienist scope of practice and a therapist scope of practice, is adjust restored surfaces in relation to periodontal treatment, so your plaque retentive factors. If you've got a patient, you're giving them treatment, they are holding onto plaque in those areas, or they're getting staining and it's plaque retentive, there's nothing stopping you from polishing it. And we did speak to indemnity companies, and Lauren and I, when we put these courses together, we spoke to indemnity companies who were of the same mindset as us, that you can use whatever you need to use in order to undertake your full scope of practice. So if that means using a fast handpiece, a slow handpiece, if that means using a polishing wheel, and that's going to help you achieve your scope of practice, then you can use it. But I would always say, be safe at all times. Put your patient first at all times, and make sure you've done the training and you're empowered with the knowledge that you feel confident, competent, and able to provide those kind of treatments, just in case. So here we go. When are we going to, I just realized how much time I've got left, not a lot. When are we going to adjust? Well, if you've got composite restorations that are plaque retentive factors, you can take as long as they're well bonded, you can take a small burr to remove overhangs. You can use, you can take off these retained orthodontic cements that are causing biofilm attachment as well. So anywhere where it's well bonded. This is a nice case as well. It's a patient that came in to see me. He just had his braces off, and he was like, my gums are just really sore, and no matter what I do, they don't feel clean, they feel really rough. And it was all of this composite that had been left over. So we were able to really help him to look after and maintain his teeth. Obviously, I wouldn't be suggesting you adjust anything that's poorly adhering. So if you've got fillings that look like they're going to pop out, overhangs that you can't get to without causing trauma, if there's any secondary caries, be careful of enamel fractures, be careful about what you can see on radiographs, and obviously don't undertake anything that you don't feel confident to do. But the way you can do it is, the first thing is maybe trying to use slow speed handpieces first, and make sure that you're using something where you can be in control of the speed of it. Typically, you want to be less than 40,000 RPM, and you want to make sure that you're using something with a lot of control. So you're sitting comfortably, you've got good retraction, and you're trying to just polish. So it might be with a burr, it might be with a soft flex disc. You're just trying to polish the part of the restoration that is causing an overhang. Here are some of the things that I use. So you'll see the soft flex discs there. There's the Enamelize polishing paste, and then you've seen the Colza polishing wheels as well. I think a lot of you will be comfortable already using polishing strips or Epitex as well. All of them have different results, and what we found is that polishing systems that are multi-step polishing systems, like this one is by Meisinger, and it's also in my kit. Multi-step polishing systems like this tend to get the best, smoothest finish and the most stain resistance. So I'm going to take you through. Do you remember we did that air polish on the Mr. Plastic's teeth earlier on? Well, here they are, and the laterals have composite restoration. So both the laterals have had composite restorations that have now slightly lost their patina because they've had air polishing on them. Okay, so what I tend to do is take the polishing wheels and make sure that I'm using my slow handpiece at a really low RPM. So I've moved it down to 10,000 RPM. And I like to always make sure these composites, when we're using these polishing wheels, are damp, because it tends to work a bit better. Not sopping wet, but damp. And what you're trying to do with these is actually move in a cross-hatching kind of motion, which you'll be used to doing with scaling as well. And I always say polish from the composite to the enamel, because you don't want to be polishing into the margin where the composite meets the enamel. You want to be feathering that margin towards the enamel, making sure that there's no ledge. So with a low pressure, really gently, barely touching the tooth, you're polishing in multiple different directions. And then you're going to do the same thing, feathering that infinity edge, but this time with the next next down in the terms of abrasivity. So usually with these wheels, the darker the color is, the more abrasive it is, similar to soft flex disc. And you can see how quick that was. It's really weird seeing me with no gloves on, right? You can see how quick that was. It's brought up that shine really beautifully and really quickly. So this is just a couple of seconds at the end of the hygiene appointment, just a couple of seconds. And you can see it's created that gloss and that shine. The other thing you can do is soft flex discs. So obviously there are different levels of coarseness on your soft flex discs. And those two top ones, that dark red and that deep orange, they're really quite coarse, and they will adjust the anatomy shape of your composites. So what you'll find is if you're using those, you will change the shape of the composite. Be very wary. If I'm just finishing or refinishing a composite, I don't use those two, okay? Unless there's like an obvious ledge. I'll go straight for the last two, which is your orange and your yellow soft flex discs, and they're really lovely. You can use those for just polishing and finishing. So you'll see the little technique here. I'm slightly bending the disc against the tooth, very slightly bending the disc against the tooth, and just giving it a little polish over, just to bring that patina back. And then once you've done that with your orange, you move down to your yellow. Told you I'm filming this one-handed, didn't I? You move down to your yellow, and again, just slightly bending that disc against the tooth in multiple directions, just to bring the shine up on there. All right, and you can get a really lovely result just with some soft flex discs, especially if that composite hasn't had a polish for a long time, or it's not been maintained, or you've lost the patina. And then there's composite polishing pastes, and I actually really love using these just on a nylon brittle brush. There's no reason why you can't do this. So just adding your composite polishing paste. I like to do this at the end, but you could do this all on its own with no other polishing involved, no soft flex discs, no wheels. You could just go straight for enamelize, or this one is Prismagloss, and there's loads on the market that you can use that are really fantastic. So again, it's just a case of bringing that nylon brush. I like to use nylon, or sometimes you can get goat's hair brushes that are really nice if you have those available in your practice. And that will just bring up the shine again. This is one of your goat's hair brushes that I just mentioned. So I find the points like this really great for posterior composites. If you've got composites on back teeth that have picked up a load of stain, or they're really rough, or they're plaque retentive factors, you can go over with these goat's hair points, and that will make them feel really shiny. Sometimes my patients say, oh, that composite, that filling now feels like some sort of chewing gum or something because it's so smooth. That's from goat's hair brushes. They do a fantastic job. All right, so there's the before and after. So the shine has come back, right? It's still got some pitting in that composite. It's still got, maybe some roughness, but we have brought back the shine that it lost just from having a more aggressive air polishing done on it. So you're going to give some post-op advice. You're going to say, avoid dietary stains, low RDA home care. So make sure your toothpaste isn't aggressive. No smoking after we've had our hygiene appointments ever, but for an hour. And then consider some tooth whitening top-ups as well, because although tooth whitening gels don't change the color of composites, it can stop stain molecules that are organic stain molecules sitting on the surface of composites or around the margins. So if your patient had their teeth whitened prior to having their composite bonding, it can be helpful to continue that tooth whitening even though they have composites. As always, it's really important to make sure we stick to a patient-centered approach. So you have to make sure that they're both medically and clinically suitable for the treatment you're giving them. And before you give them that treatment, educate them on making sure they don't need the treatment again. I try and say this to a lot of my patients. My role is prevention. The whole point of a patient seeing me is to stop the patient from needing to see me. That's how I feel anyway. So education comes first. Then I like to air polish with a system that's suitable for the patient's situation. So obviously, ideally, we'll just use low format, subgingival glycine or organic powder particles on all of our patients, right? Whoever's allowed to have it. But there might be one or two cases where you need to go for a bit of a more aggressive powder to get the stains off, to actually get it off. And if that's the case, then discuss the need for further polishing or refinishing, either with yourself there and then or with the dentist. Not a massive fan of consent forms, but if a patient comes to me with a mouthful of composites, desperately need a load of maintenance and lots of work, then they will get this consent form for polishing composite bonding. And again, feel free to just pop me a message. I don't mind sending this out, but you can also just screenshot if you want to. And you can see the kind of things that I've got written on my consent form for that. Things like explaining what we're doing, explaining what the risks and the benefits are, and asking the patient to consent to the treatment. Okay, and I always like to tailor that to the patient in the additional comments and notes. It's really helpful having that because it shows that you've spoken specifically to that patient about their specific situation. We made it, guys. Take home messages. We need to adopt the most minimally invasive approach we can when it comes to looking after our patients and their restorations. Obviously, home care instructions are of paramount importance. So how they can avoid the stains from building up in the first place, the fact that they need to cover regular hygiene appointments. And then air polishing when necessary in surgery. I like to use glycine, but heavily stained composites may need refinishing. Edges or ledges may need polishing away, either with slow or fast handpiece, with whatever you feel comfortable with. Whatever you're going to do, make sure you get your patient's consent. Lauren Long and I are running Powered Proficiency, which is how to achieve that precision in practice with all the different powered tools. And it's for both hygienists and therapists. And the next date is on the 22nd of March next year. So this course is a full-day hands-on course teaching hygienists and therapists how to be confident in adjusting overhangs, in polishing composites, in maintaining their patients using powered instruments. So we're talking piezo, fast and slow hand pieces, and your air polishing devices. In addition to that, you can come and see us, the whole Ikigai team, at the NSK stand at the OHC this year. So we're going to be in Harrogate on the 22nd and 23rd of November. Both the Friday and the Saturday, we're running my composite course. So you get 90 minutes of placing composites with myself if you book in time. We've also got Catherine and Jenny, who I mentioned earlier, doing implants, and Lauren's running through composite maintenance as well. So come to the OHC, come and visit us at the stand. You need to book in advance. They are always sold out and they are always really fun sessions. And talking of loads of fun, I have launched my 2025 course dates very recently for my posterior and anterior composite courses. So if anyone fancies coming and having a whole day playing with composites with myself, I would love to see you there. Manchester's almost fully booked. Edinburgh is almost fully booked, and Newcastle is almost fully booked. So get in there while you can. You can just pop over to my website. And then finally, there is a discount code for those of you that are watching tonight. There's a lot of you on this evening, so thank you so much for joining me. There's a discount code off the NSK web shop. So if you or your practice are looking to buy any NSK equipment, it's only valid until the 27th of October. So get it down, and it's this WCE1024 code. And just quickly before you jump in, Siobhan, I have noticed Gemma asked, quick recap, yeah. Soft pearl needs to go in PerioMate Neo. So Gemma, no, the soft pearl, which is the new larger format glycine, goes in your normal supragingival ProfiMate handpiece. So it's a big powder particle, so it goes in the big supragingival handpiece. Thanks. That's me done.
There's quite a lot more actually. Lots of questions. Can you use glycine erythritol powder in a ProfiMate handpiece, or does it need to be a PerioMate?
So it depends on the size of the particle, but if it's small, low size particle powder, so your erythritol or your perioglycine powder, that will go in your subgingival or your PerioMate handpiece.
How do you recreate the luster on the bonding and also natural teeth? And do you do anything different for edge bonding?
So the only thing I would say is when it's edge bonding, obviously there's going to be a margin, and it's really important to move your polishing from composite to enamel so that you're feathering that margin rather than digging into and recreating the margin. And I don't do anything particularly different to get the luster. It's just the tools that I've shown you today. So if the fillings are looking pretty good, but they just need a bit of a polish up, I'll use the Enamelize. Really love that paste. Really fantastic on a brush, but otherwise I do really like the polishing wheels. They give serious luster. We're talking mirror finish to those. Enamel shouldn't really need you to create more luster. If it isn't shiny, then maybe it's naturally that way. So just bear in mind that some people just don't have shiny enamel.
By the goat's hair brushes, is there a material and instrument list? I'm sure you have one, do you, Kat?
I'm sure I can get one together. Pop me an email, anyone that wants an equipment list, because I can get one together for you, but might take me a day or two.
About staining under margins.
Yeah, so we've got to be a bit careful, haven't we? We don't want to be digging off enamel or composite, sorry. We don't want to be digging it around, because essentially what you're going to do, if you think that that composite margin has feathered out, so it's only going to get thicker, the composite, as it gets deeper. So if you start digging around under a margin, you're going to create the further problems for the patient. And this is where we need to feel confident in saying, this patient, you know, this isn't for me. I can't get this stain off. There's not much I can do about this one. You either need to have it replaced, or you need to accept it as it is, or, you know, come back, go back to the dentist that placed it and ask them to polish it away.
Do you recommend the soft bristle head for the Oral-B IO on bonding?
No, to be honest with you, I'm not a massive fan of soft bristle brushes. That might come as a surprise, but I find that it's not really about the brush bristle itself. It's more about the muscle that the patient uses behind their brush. And no matter how soft your bristles are, if they're pushing too hard, they're going to cause trauma or problems. So it's all about education for me. It's about demonstrating to the patient what they should and shouldn't do, and staying within that. I love the Oral-B IO brush just for the fact that it has that too soft and too hard, and I just want them to be just over the too soft when it comes to cleaning their bonding.
How do you remove interproximal corseal staining?
With an awful lot of difficulty, but air polishing just does it for me. Air polishing, really fine tips on your scalers. So I personally use LM. You know, they have the Sharp Jack scaler, which is amazing. I love that. And then put at a push a small little bit of Epitex tape in between, but I'm not a huge fan of using that on a regular basis, but at a push, I would use some Epitex tape.
Okay, and how do you remove cervical composite bonding overhangs?
So I would take a really fine, thin diamond burr and smooth that around the overhang edge. And this is something that Lauren and I go into in really deep detail when we do our hands-on course, the one I was mentioning before, in March. So yeah, you take this really long, thin, fine red or yellow band diamond burr, and you're going to smooth that over until your overhang is gone, and then the whole composite surface needs refinishing. But yeah, it does take skill and patience and time, and you need to be very confident. So come on the course and find out more.
That's all your composite bondings. Do you prefer using the wheels and enamelays, or just one of them?
I tend to just use the wheels, to be honest, because they give you that mirror finish, and because I'm able to choose the composite that I'm using, and I'm making sure that I'm using nano hybrid composites, I'm really confident that once I've got my luster on there, it's quite unlikely that the patient is going to need a refinish anytime soon, depending on obviously how they treat it. So yeah, the enamelized for me is more when people come in and I feel like their composite needs a little extra, something more.
Do you recommend the Diamond Ultrasonic NSK tips, and what for?
Yeah, I use the Diamond Ultrasonic tips. They're really good. They are for perio. When you've got tough spicules of subgingival calculus, I really like to use the diamond just when I'm doing perio in those areas where I'm really struggling to get those tiny, tiny, really tough spicules in some areas. You have to be careful. They can cause some damage on the dentine, but they're really good for that. So that's one type of diamond tip. There is another type of diamond tip that you can use, which is a restorative diamond tip. And I go through this in quite a bit of detail on the Modern Therapist. You can use a restorative diamonds tip, which is different types of diamonds. And I can't stress that enough. It's a different type of diamond, and it will actually cut the enamel. But it's wonderful to use when you know what you're doing it for. And it will really massively increase your bonding surface for your composites. If you're interested in having a go, come on the Modern Therapist, because if you do the Modern Therapist course, we run through how to use them, and you get given a free diamond restorative tip by NSK. So that is just worth it as far as I'm concerned.
Quick recap: soft pearl needs to go into the Perio Mate Neo handpiece.
So soft pearl is the new, I'm going to get the picture up again because it is confusing. I completely appreciate that it can be really confusing. Let's find it, Siobhan.
And while you're there, can you reshare the QR code for booking the course in March, please?
Oh yes, I will do. I'll come back to that one. So this is soft pearl. It's relatively new. It came out last year. And it is a larger micron powder. So it means it has to go in the supragingival handpieces. Okay, it will not go in the subgingival handpieces. It will clog it up. But it's still made of glycine, so it dissolves, which is amazing. Patients love it. They don't have that mouthful of grit. So no, it's you can feel it in your fingers. If you can feel the powder is gritty in your fingers, it's very likely to need to go in a supragingival or normal polishing, not a subgingival. And let me get you that QR code. I hope it still works. I put it up there without thinking about whether the QR code worked. I'm sure it does. I don't think Lauren's changed anything on her booking system. Da, da, da. All the videos. There it is. Please, please, please book in, because we love running this day. It's so much fun, and we get to do so many cool things, and everyone gets to,
just check that there, and if it doesn't come up, we'll find the link for you. And sorry to ask something slightly different. Would you polish crowns? I've always avoided them, but today 2 patients told me they always get them polished.
Yeah, I would polish them normally with subgingival small format glycine powder. So I would happily polish them with that. And I'd also polish a crown with prophy paste, right? So there's no reason not to, but I perhaps wouldn't take anything abrasive to a crown, because it's pointless. You're not going to make it any better than the glaze finish that it already has. And that QR code is working, by the way, I believe. I think you might have to scroll down a little bit to find our actual course, but that one is definitely working.
Lunos have a lovely super soft Audiave 5. So if you might want to ask them, can you have a sample of that? It's really soft.
I do.
What if you had to recreate some secondary anatomy? How do you do that? I think this is a composite course that we need to, you need to run a composite course, Kat.
This anterior composite course does go through exactly how to recreate secondary anatomy, how to put it into your composites from the inside out, but also how to put it into composites from the outside in. I know that sounds mental, but we run through both. And yes, you can recreate secondary anatomy using loads of different techniques. It's way too much to go into right now. But feel free to DM me, and I can tell you some of my little sneaky tricks and tips to make teeth look like teeth, which is the most important thing, because let's be honest, what we're born with is the most beautiful thing we could ever have, right?
How do you avoid losing the 3 planes from the side and not making the tooth flat from polishing?
Well, you need to understand your anatomy of your teeth. So again, it's all about knowing what angles you're trying to recreate when it comes to polishing, and making sure you're at those angles when you're using your polishers. If you're just polishing someone else's composites, it's unlikely that you're going to want to polish so much that you're changing the anatomy. I would really avoid that, because you've not placed it, therefore you're not being paid for it. And so you should just be maintaining what was there. But if you're placing the composite, then yes, we need to be aware of all of our anatomy, all our primary anatomy, which isn't just the initial shape of the tooth, but it's also the 3 planes that the tooth on the anterior curves through. So again, come on my anterior course, you will be blown away.
Somebody's just saying, will we be emailed our CPD certificate? Actually, an evaluation's going out on Monday. When you fill out the evaluations, the marketing will send you your certificate back, but that won't be going out until Monday morning.
Yeah.
Okay.
You have to remember until then.
What if bonding chips while scaling? How do you repair?
Yes, I mean, you can repair if it's chipped while you're scaling it. Obviously, you need to have that conversation with your patient. But I personally would repair if I felt confident that I knew what composite I'm repairing with, because you kind of want them to be the same. And then you would sandblast. I'm not talking air polishing here. I'm talking properly sandblasting with aluminium oxide, 27 micron. You're going to sandblast to get your taggy surface. You're going to still etch it, bond it, and then place your composite. Final cure under glycerin, really important. And then again, back through your polishing protocol from coarse down to fine. But again, that is a composite placement question, and that takes a day.
How do you charge your patients only for finishing polishing in a hygiene appointment? Do you book them slightly longer appointment or charge them separately?
I'm just such a nice hygienist. No, for me, it's part of the service, right? So for me, it's part of the service, unless a patient comes and they have loads of work to do, and then we'll sit down, we'll say, right, you need to check up with me. You need to then have, a refinishing appointment with myself, and then I will charge for that. And I do tend to charge between 40 and 80 pounds per tooth, depending on the situation for repolishing. But that's if it's like, widespread. But if it's just a hygiene appointment, I'm just doing a little bit of an analyze, I'm not going to charge them.
Okay, and booked, thank you. It did not show the March date, so I hope I booked the right one. You could check that, Jackie, with Kat, no problem.
Thanks, Jackie.
You'll have a great day with the ladies. Oh, yeah. How do you mirror the line angles on centrals?
Oh, well, by taking a pencil and drawing the line angles on and making sure that I push them into the right direction, depending on what it is that I need it to need myself to achieve. So again, you need to, with pencil markings, you can draw away, you can shade in the area that you don't want, and then you can be polishing until that pencil is gone, if that makes sense, and then just leaving the part that you want there to be. But yeah, it's an art, right? This is why we came into dentistry. A lot of therapists have come into dentistry because they want to create art. That's certainly what I wanted to do, and it is an art, and it takes time to really understand what you're doing. But yeah, draw on the line angles that you want, shade in the part that you don't want, and then polish the shaded part until it's gone.
Would you offer a discount if booked onto anterior and posterior courses?
At the moment, I have never discounted my courses, right? So at the moment, no, they're super busy and popular because obviously it's new. I've just released it, so it's looking really good. And it's tricky to discount because it's already really, really cheap. And so for me to be able to run these courses with the amount of equipment that goes into it, it costs a lot and it doesn't make a lot. So
I don't think people realize the cost behind the lines for these, really.
The consumables, Siobhan, it's not even the hotel that we book, the food we put on, it's not the amount of people that are, you know, being catered for, it's the consumables, you know, these
and I think that's why NSK are offering the discount for you to attend this evening, which I probably should have said is 40%, because I had to check my ears to say, you know, are you sure? And they're saying, yes, we've got the same people coming on the webinars all the time. So they're delighted to offer that to you. So that's, yeah. What's your favorite composite for bonding?
Well, it really depends. So I'm using a few different ones at the moment, and yeah, it really depends on the situation. If the patient's going to be biting on it or not biting on it, you know, it's a very much down to the patient. So at the moment, I'm using a lot of the DMG Ecosite Elements composite because I'm doing a lot of icon treatment at the moment. That seems to have blown up in my practice, and icon and Ecosite Elements, they work really well together. And then I'm loving GC at the moment. The GC composites, they've got a really great flowable like warm tone margin blocker, which I'm using for a lot of my fractured incisal edges and stuff like that to make sure that there's no margins on there. So I'm really loving GC. They've also got really great tints that I'm using. So yeah, there's a number, and it really depends on the situation with the patient. Is it just facial? Is it an incisal edge that's been chipped away? You know, is it functional? Is it not functional? So we'll choose it depending.
Get back into therapy, but it's been so long. So I graduated in 2010 and picked up a drill for 2 fillings for years, and since nothing. Would you recommend these courses for me? Would I need to do other courses before booking on these? Thank you.
No, you just come and be supported, because you might think you're the only one, but you're really not. And that was me as well. You know, I did hygiene. I qualified in 2008. I did hygiene for 9 years. And now I'm just super passionate about all of us being able to reach this thing called self-actualization. So being able to be the best you can be. And so my courses, and I know all the ones that are put on with NSK as well, it's about being inclusive and making sure that all of us can do it by the end of the day.
There is another course, Restore. That's one that Kat's partner from the other course, Lauren and Ailish, do. I think they're quite booked up at the moment, but that's going back over medical histories and all things like that as well. You might want to look out for it. And I think we're at the end. Let me just check once more. Yes, and just a few little comments just to read for you, Kat. Fabulous webinar. Thank you. Feel so much more confident when dealing with my patients with composite bonding. And thanks, Kat and Siobhan. Great webinar. Can you bring it to Manchester? Your courses. Thanks for tonight. Oh, the discount code. I've put that back on. Thanks so much, Kat, for a great webinar. It was excellent. Great webinar. Looking forward to Anterior Composites in Newcastle in January. Thanks, Kat, for a great webinar. Useful tips and tricks. Excellent as always. Thank you. So I'm going to end there. And you're a star, Adrienne is saying. Thank you, everybody, for turning up. The evaluations will be coming out on Monday. Fill those in, and marketing will send you out your certificates. And we're going to see you back here to see Kat in a few weeks' time.
Yeah.
So where are we again, Kat?
That is going to be on ultrasonics, or is it on air polishing? We've got one
Air polishing on the 17th. Where are we?
It is so busy.
14th of November, and then we've got another one in December. So one a month to look forward to. So thanks
Amazing.
very much, Kat. Really enjoyed that. Really good. Thanks a
Thank
million.
you everyone for joining us as well, because we couldn't do this if it wasn't for you guys joining us and, you know, making us feel like it's doing something for you and making your lives easier. So appreciate the audience and thank you for your time, Siobhan.
Brilliant. Yeah. You really are one of the nicest human beings and very generous with your knowledge. Isn't that lovely?
Oh, that's so lovely. How sweet.
It's a million, Kat, and we'll end here and we'll see you back in a few weeks.
Wonderful.
Take care now. Bye now. Bye-bye.